Hello everyone, and thank you. I'm going to talk today about virtual reality and use in the NHS. And I'll be talking about my own experience of working with patients in primary care, specifically my practice in Eastbourne. But first, a little more about me. My name is Dr. Keith Grimes. I've worked as a GP for 16 years, mainly in urgent care, and I see a huge variety of patients every day of the week. I'm also a geek and a gamer. And in truth, I'm probably more of the latter than the former. I've certainly been geeking and gaming for longer than I've been a doctor. As a result of this, I've spent my entire career trying to bring medicine, technology, and gaming together. And it's never been easy, but lately there's been more of an interest in this area. And I like to think of myself as a digital healthcare innovator, combining the three. And whilst I've had success with a number of different technological innovations, VR is somewhat new territory for the NHS. So, what role is there for VR in medicine? Today, I will argue that VR has an important role in medicine right now and will have an increasingly important role in the future. I believe that virtual reality can make existing treatment more effective and tolerable. I believe that it is a novel therapeutic modality and a novel diagnostic tool. I believe that VR can improve education and training for patients and doctors. And I also believe that VR can increase empathy and break down barriers. All of this was theoretically possible with VR the first time round in the 1990s. However, now I believe the technology is good enough to deliver on this promise. What's more, the technology is widely available, relatively cheap, and increasingly in common ownership. And all of this allows for experimentation. Now, as is traditional, I'd like to start with a definition of virtual reality. And there are many, but most sound pretty similar to this one. Virtual reality, or VR, is a computer technology that uses software-generated realistic images, sounds, and other sensations to replicate a real environment or an imaginary setting, and simulates a user's physical presence in this environment to enable the user to interact with this space. The importance of this definition is that it clearly describes the four principal components of VR. First, that it is software generated and produces images, sounds, and other sensations. Now, VR can also use touch, proprioception, and even smell to complete the second part, that VR replicates a real environment or imaginary setting. Thirdly, that the physical presence of a user is simulated, which, in turn, is augmented by the fourth part, that the user can interact with the virtual environment. And when you have all four, you have that key characteristic of virtual reality, immersion. Now, it also helps to know a little of the history of virtual reality, which certainly goes back further than recent developments. Again, there are lots of different versions of the history of VR, but what is common is a reference to a short story called Pygmalion Spectacles. Written by sci-fi author Stanley Weinbaum, this 1935 short story tells of a man who experiences a simulated virtual world by wearing a pair of special glasses. And whilst the term VR is not used, the characteristics of the experience of the protagonist are undoubtedly those of a person experiencing virtual reality. In the story, it turns out that the reality the explorer experiences is simply a transmitted close-up of a scene filmed elsewhere, which happily means the woman he falls in love with actually exists. Next, we have the exciting sounding Sensorama. Developed by Morton Halick, he used stereoscopic cameras and speakers, physical linkages to simulate movement, and even wind and odor generation to create a form of mechanical virtual reality. The initial 6 movies covered everything from dune buggies and belly dancers to the journey of a Coca-Cola bottle. Ultimately, the product proved too expensive to scale. The first computer-generated VR, fitting our definition of VR, was that made by Ivan Sutherland. The resulting headset was so heavy, it had to be suspended from the ceiling, hence the name, the Sword of Damocles. And there were further refinements, but the next big leap forward happened in the mid-80s with Jaron Lanier and the VPL. He reputedly coined the term virtual reality, and not only produced the Data Glove for interacting with VR and the iPhone that's EYE phone, but also Body Electric, the visual programming language of VR. Although he was bankrupt by 1990, his work ushered in the first summer of virtual reality. Many people, myself included, will have been introduced to VR in the early 1990s. Thanks to Jaron Lanier and the rise of interest in cyberpunk authors like William Gibson and Bruce Sterling, the public at large became excited by the possibilities of VR. Game systems like Virtuality, here pictured on the left, were available in places like the Trocadero in London. We had movies like The Lawnmower Man and TV series like Oliver Stone's Wild Palms. And predictably, everything was horribly overpromised. So whilst there were lots of incredible ideas, many clinical, the technology simply couldn't deliver. Over the next few years, despite attempts by Sega and Nintendo to deliver VR platforms, it quietly vanished from public view. Despite this, research continued, as did a niche of practical applications in architecture and engineering. This remained the case until about 4 years ago, when a teenager called Palmer Luckey developed a prototype new VR headset he called the Oculus Rift in his garage. Delivering a high-quality, low-latency VR experience was a huge Kickstarter success and signaled the second summer of virtual reality. Thus, in the past 4 years, we've seen Samsung, Steam, Facebook, Google, and Sony all join the fray. Everything from cheap cardboard headsets you use with your phone, through PlayStation hardware, to high-end PC-based solutions are now in the hands of an inquisitive public, such as myself. Now, at this point, I'll bring up the other ubiquitous slide when discussing tech, the Gartner hype curve. First developed by IT research firm Gartner, it illustrates the maturation of emerging technologies through 5 phases. The technology trigger. A new technology is born, and early examples generate some interest. The peak of inflated expectations. A profusion of examples, some succeeding and some failing. The trough of disillusionment. Waning interest, as the promise fails to materialize. Then you have the slope of enlightenment. As the tech is better understood, more beneficial technology is developed. And then finally, the plateau of productivity, mainstream adoption. Looking at the history of VR, you can see how it fits this curve quite nicely, from the technology trigger in the 60s, through to peak expectation in the early 90s, and the downward slope of the mid-90s to where we find ourselves now, the slope of enlightenment. The question is whether this continues into the plateau of productivity. Anyway, this is where my story starts. And I'd like to tell you about one of my patients. We'll call him Adam. And Adam is one of my favorite patients. He's in his 50s, he loves rugby, and he's built like a prop forward. And that's handy because he was one, semi-professional for many years. As a result, most of our consultations include talking about rugby and the fights he got into. And he's retired now. And among his health problems are leg ulcers. You'll all understand how these dressings can be painful. And between talking about the rugby, he would often become tearful at the level of pain he was experiencing during these dressings. And one day he asked me, only something could distract me from the pain, doc. Now, pictured on the right is my Gear VR headset, which I've recently acquired. And you can probably guess where this is going. How does virtual reality work in acute pain? This is the point at which I talk to experts in pain and its management about how VR might work for pain. So as a generalist, I'll keep it to my level, and I'll apologize in advance. The mechanism by which VR reduces the perception of pain is not fully understood, but it is the subject of research. Most people consider VR simply as a form of distraction, but a more modern understanding builds on existing knowledge. To start, the gate theory of Melzack and Wall. This suggests that competing non-painful stimuli can inhibit the transmission of painful stimuli to the CNS. Next, McCall and Mallett have proposed a limited capacity for attention to pain, which might explain how the immersion and distraction of attention experienced in VR might attenuate pain perception by diverting attention away from painful stimuli. Wickens further proposed that in the multiple resource theory, which postulated that those resources for attention to sensory stimuli function independently. As VR works across modalities, this is thought to contribute to its superiority in delivering analgesia. And finally, Gold proposed a theory of intercortical modulation of the pain matrix, recognizing how the emotional and cognitive components of central pain affect its perception. Looking at the evidence, again, there is a growing body of this. The first published evidence of what we would recognize as VR providing analgesia comes from Rose in 2000, when he published 2 patient case series using VR to reduce pain in dressing changes for burns victims. The VR used was Spider World, where the patient would interact with a kitchen scene, which included handling a spider with haptic feedback. Further developments of this technology included Snow World, here pictured on the right, and more recently Cool from Deepstream VR. Applied VR is a startup that's also provided a platform for use on mobile platforms. Getting back to my practice now. Now I don't have Cool, I don't have Snow World, I don't have Applied VR. I just have my Gear VR and a phone. And I knew a little bit about VR and pain control, and I was fascinated by the potential. And one day, Mary came to see me. Mary is a lady in her 30s who'd just given birth. She was also troubled by a pilonidal abscess, which needed frequent dressings. And you'll all be aware that this is painful and distressing for some. What's more, Mary was breastfeeding, so it was even harder to find something that wouldn't be passed on through the breast milk. She came to me because she was struggling. She was also really anxious and upset by these dressings, and fearful of having a definitive operation to fix things, because she'd need further dressings. Now, at this point I had a choice, but because I'm equal parts geek, gamer, and doctor, I felt VR was worth trying. So I discussed VR with the patient. I explained what I knew about it and what I thought were the potential pros and cons. And to Mary's credit, she decided to give it a go. And on the 9th of May, 2016, I got to use VR to reduce pain for real with a patient. And the question you'll be asking is, did it work? Well, of course it did. I mean, I wouldn't be standing here if it didn't. The quote at the top is from Mary herself at the end of the week we tried VR. I used off-the-shelf content in Gear VR. So on day 1, we used Introduction to VR from the Oculus store. Over the course of the week, she also watched the Cirque du Soleil, 360 YouTube videos, and more. And she reported between a 50 and a 90% reduction in her pain. What's more, she had significant reduction in the anxiety experienced when having the dressings. On more than one occasion, she didn't even realize that we'd finished. The nurses, they were also impressed. They were freed up from trying to rush through the procedure and having to distract the patient. The patient has also consented to having a definitive operation to fix this because she knows that she can use VR in future. Now, this is just one patient, but I was sufficiently impressed that I decided to investigate things a little further. And I've since embarked on using VR in my practice for many more patients. And I've used it for wound care, like with Mary, but I've used it for undertaking incision and drainage and joint injections. And we've even tried it for blood tests. Now, I'm no fan of that. That's me in the top right. And it worked well. What I've found is that it remains pretty effective for many patients, although those high anxiety or procedures that generate the most fear tend to benefit the most. I've also found that gamers are particularly susceptible to the effects. One patient, a man in his 20s, again with a pilonidal abscess, would scream the place down during his daily dressings. Yet, when I gave him Eve Gunjack to play, he was focused, calm, and crucially, much less sweary. And the evidence shows that the more senses you recruit using VR, such as sight, sound, motion, and intent and focus, the greater the level of pain relief. Everything I've achieved this far has been on commercially available technology. My Samsung mobile phone and Gear VR headset and the content that's available on that platform. Developing bespoke content or applications opens the field up much more widely, with the potential clinical uses in primary care. Mental health. This is an area that predominates in primary care, and here it's that VR looks to have some of its greatest potential benefits. Now, this bathroom that you see here is possibly the most disgusting one since Train Spotting, and is provided courtesy of a company called Mindwave. Health VR is a virtual environment used for treating obsessive compulsive disorder. It can be tailored by the patient and clinician to allow for graded exposure to a distressing environment, in this case, a bathroom. And having experienced it myself at maximally filthy settings, I can report that it was extremely convincing replication of some of the most extreme examples I've seen in my time visiting homes as a general practitioner. For phobias, you have market-ready applications like ITSE, which is currently being studied in Sweden against traditional one-session exposure therapy for spider phobia. And I've been exploring the use of social VR to consult patients in virtual reality. Some of my early findings suggest that it might have useful and unique properties in doctor-patient interactions. And finally, there is psychological resilience through VR exposure as a novel therapy for ICU delirium, or prevent ICU delirium. And this is the reason I've become involved with the Northwest London Critical Care Network. Developed in conjunction with Alex Rosenberg and Sunil Bhudia, we hope to build a VR application that might help reduce post-operative delirium in ICU patients. I'll let Alex tell you more about this in his next talk, and I'll present my own talk about this in future. And with that, I'd like to close. Thank you for your time. Thank you for your attention. I've only really scratched the surface of what's potentially possible with VR and 360 video. So if you'd like to know more and get in contact, you can reach me via my website or on Twitter. I've also formed a discussion group about clinical VR on Facebook called VR Doctors, and you're all very welcome to join. This presentation will be available online on my blog and Twitter this evening, but if you have any questions, I'd be happy for you to answer them now. Thank you.